and our chief, Dr. Padma.
Yes.
And I also welcome all the respected faculty, moderators, presenters, and PGs from all colleges who have taken time to share their valuable knowledge with us today. Your enthusiastic participation makes this meet a great learning experience for all of us.
Thank you, Ponmoli. I think we will begin the sessions. The first session is by Harida Sri, our first year PG from Male Marvatur Medical College. Harida, please take over.
Good afternoon, everyone. I'm Dr. Harita Sri, first year postgraduate, Department of Pediatrics and Neonatology, Main Marvatur Medical College. I'm going to present on the topic of carpet.
Just one moment. Is the screen visible to everybody?
Ma'am, slides are visible.
Visible? Slides are visible?
Yes, ma'am. Yes, ma'am. Slides are visible, ma'am. We can proceed.
Please proceed.
I'm going to present on the topic of carpidium, blue babies at birth. We have received 2 babies delivered in our institution with a complex congenital heart disease. The first baby was delivered by emergency LSCS for impending scar dehiscence to a P2L2 mother delivered at term gestational age. Antenatally, baby was diagnosed with double outlet right ventricle with pulmonary stenosis. Baby cried at birth with the Apgar of 6/10 and 7/10. Baby weighed 3 kgs at birth and other parameters were found to be normal. On delivery, the cry and activity of the baby was weak. Vitals were monitored, which showed heart rate was 140 per minute. Baby was tachypnic with a respiratory rate of 68 per minute. Central and peripheral pulses were found to be equal and normal on both sides. Capillary refill time was less than 3 seconds, and saturation was found to be 84% in room air. On cardiovascular system examination, first and second heart sounds were heard. Systolic murmur was heard. Respiratory system examination revealed bilateral subcostal retraction, bilateral air entry equal, and no adventitious sounds. For abdomen examination revealed abdomen was soft and no organomegaly. Central nervous system examination was within normal limits. In the view of above mentioned findings and history of antenatally diagnosed complex congenital heart disease, baby was shifted to NICU for further management. Baby was started on bubble CPAP at the minimal setting at FiO2 for 21% and PEEP 4 cm of water. Baby was started on alprostadil infusion at 1 ml per hour as baby receiving 0.1 mics per kg per minute. X-ray was done which showed levocardia with cardiomegaly and obliteration of pulmonary bay with normal pulmonary vasculature. Echo was done which showed transposition of great arteries, tight pulmonary valve, large patent ductus arteriosus, large ventricular septal defect with bidirectional shunt, small atrial septal defect with left to right shunt. All chambers were dilated. Baby was referred for further pediatric cardiologist and cardiothoracic surgeon consultation. The second baby was delivered by emergency LSCS for maternal request to a P1L1 mother at term gestational age. Mother was over diabetic on insulin and hypothyroidism with on tablet thyroxine. All requisite scans in the antenatal period, including dating scan, NT scan, anomaly scan, and growth scan, were found to be normal. Baby cried at birth and Apgar was 8/10 and 9/10. Baby weighed 3.5 kgs and other parameters were found to be normal. As the baby was born to the over-diabetic mother, serial CBG monitoring was done. At 2 hours of life, CBG was found to be 28 mg per deciliter and baby was asymptomatic. After 1 feed, the CBG was measured, which was 34 mg per deciliter. for which baby was shifted to NICU in the view of asymptomatic hypoglycemia and started on 10% dextrose. Vitals were monitored, which showed heart rate was 110 per minute and respiratory rate was 60 per minute, with central and peripheral pulses were felt normally and equally on both sides, and capillary refill time was less than 3 seconds. Saturation was found to be 85% in room air. Cardiovascular system examination showed first and second heart sounds were normal, and systolic murmur was heard over the aortic area. Respiratory system examination revealed bilateral air entry equal and no adventitious sounds. Per abdomen examination, abdomen was soft and no organomegaly. Central nervous system examination was within normal limits. X-ray was done, which showed X-ray was done, which showed levocardia with a cardiomegaly and globular heart shadow with normal pulmonary vasculature. Echo was done, which showed membranous pulmonary atresia with patent ductus arteriosus with left to right shunt. Baby was started on IV fluids and aldosterone infusion at 1 ml per hour, as baby receiving 0.1 mics per kg per minute. In the view of critical congenital heart disease, baby was referred to pediatric cardiologist and cardiothoracic surgeon consultation. A few words about duct-dependent circulation. During fetal life, blood is shunted from pulmonary artery to aorta through ductus arteriosus. Physiological closure of ductus arteriosus occurs at 24 hours of life. If ductus arteriosus remains patent in normal heart after birth, it leads to left to right shunt. Site of ductus arteriosus is just distal to the origin of left subclavian artery. Patent ductus arteriosus is vital for life in critical congenital heart diseases where pulmonary or aortic blood flow is critically restricted due to severe stenosis or atresia. In these babies, closure of ductus arteriosus results in marked cyanosis and severe respiratory distress. Critical congenital heart disease are broadly classified into duct-dependent pulmonary circulation and duct-dependent systemic circulation. In conditions like critical pulmonary stenosis, blood flow through pulmonary artery is severely compromised. Only when the patent ductus arteriosus is present, some amount of blood flows from aorta to pulmonary artery to maintain oxygenation to tissues. Similar mechanism is seen in other conditions as pulmonary atresia with intact interventricular septum, tricuspid atresia, tetralogy of Fallot with severe pulmonary stenosis, Epstein's anomaly, transposition of great arteries with pulmonary atresia, in case of conditions like interrupted aortic arch, the blood flow from systemic circulation is severely compromised. Only when the ductus arteriosus is patent, blood flow from pulmonary artery to systemic circulation, which improves perfusion. The similar mechanism is seen in other conditions like hypoplastic left heart syndrome, critical aortic valve stenosis, critical coarctation of aorta, a few words about pulse oximetry screening. This is very vital screening which can be used followed to detect the above mentioned critical congenital heart diseases. Pulse oximetry screening should include measurement of saturation in both preductal, which is measured in right upper limb, and postductal lower limb. Pulse oximetry screening should be done after 24 hours of life, or if the baby is getting discharged before 24 hours of life, it can be done just before discharge. Ideally, the pulse oximetry screening is done between 24 to 36 hours of life, as it decreases false positive results due to respiratory ailments. Pulse oximetry screening is done after 24 hours of life. It is measured in one right upper limb and 1 foot. If the pulse oximetry screening is less than 90% in either right hand or foot, then it is denoted as the test is failed. So the baby should be proceeded with immediate clinical assessment and further management like X-ray or echo. And if the pulse oximetry screening done seems to be more than 95% in both sides, or a saturation difference is less than 3%, then the baby is passing the pulse oximetry screening test, and the baby can be proceeded with the routine care and discharge. And if the pulse oximetry screening is less than 95% in both sides, or the pulse ox difference is more than 3%, the test should be repeated after 1 hour. And if the repeated test give the result of the pulse oximetry screening more than 95% in both sides and the difference less than 3%, then the pulse oximetry screening appears to be passed. And if it is not more than 35%, and if the difference is more than 3%, then the test is failed, and the baby should be proceeded with further management of echo and pediatric cardiologist and cardiothoracic surgeon. The conditions which can be detected by pulse oximetry screening includes hypoplastic left heart syndrome, pulmonary atresia with intact ventricular septum, tetralogy of Fallot, transposition of great arteries, tricuspid atresia, truncus arteriosus, double outlet right ventricle with cyanosis, Epstein's anomaly, critical pulmonary and aortic stenosis affecting systemic output. Non-cardiac conditions detected by pulse oximetry screening includes hemoglobinopathy, hypothermia, infection including sepsis, lung diseases which are acquired and congenital, non-critical congenital heart defect, persistent pulmonary hypertension. Conditions not detected by pulse oximetry screening are ventricular septal defect, atrial septal defect, coarctation of aorta, total anomalous pulmonary venous circulation, mild pulmonary stenosis, and mild aortic stenosis. In case of coarctation of aorta, which can be missed by pulse oximetry screening, so it is essential for us to examine the femoral pulse for the baby in order to arrive at a diagnosis. Evidence of pulse oximetry screening in newborn routine screening. Pulse oximetry screening detects critical congenital heart disease with a sensitivity of 76.5% and specificity of 99.9%. False positive rate of detection for critical congenital heart disease is lower when pulse oximetry screening is done after 24 hours of life. Few words about alprostadil. It is a prostaglandin E1 analog. It primarily acts on E-prostanoid receptor, which is a G protein coupled receptor linked to a GS protein, acts by increasing the adenylyl cyclase activity. Activation of EP receptor causes increase in cyclic AMP inside the vascular smooth muscles, thereby activating the protein kinase A, which in turn decreases the intracellular calcium level, causing relaxation and vasodilatation of smooth muscles. It also decreases the pulmonary and systemic vascular resistance and increases oxygenation by maintaining ductus arteriosus patent. The drug is available in the form of injection at 500 mics per ml, and 1 ampule contains 1 ml. The drug should be initially started at a rate of 0.05 to 0.1 mics per kg per minute. It can be given up to 0.2 mics per kg per minute if necessary. Then it should be lowered to the maintenance dose of 0.01 to 0.4 mics per kg per minute. When there is increase in partial pressure of oxygen is noted, immediate decrease in the drug to the lowest effective dose should be done. These are the available brand of alprostadil in India with their respective cost. The drug are apnea in newborn baby weighing less than 2 kgs, fever, and other rare side effects include seizure, flushing, bradycardia, hypotension, diarrhea, gastric outlet obstruction, reversible cortical proliferation of long bones. Take home message. Early in utero referral of critical congenital heart disease. Routine pulse oximetry screening should be done for all the babies after 24 hours of life, and early initiation of injection alprostadil in duct-dependent circulation for saving life. The references are taken from Nelson Textbook of Pediatrics. Thank you.
Thank you, Harita. That was a nice presentation, a nice overview of an approach to a child with abnormal pulse oximetry screening. Does the moderator have anything to say? Any questions from the audience?
That was an excellent presentation, ma'am. Myself, Dr. Ashok from SRM Medical College. The presenter pointed out, it is a very valid point that pulse oximeter screening is essential, and we are routinely doing. Just for the benefit of PGs, I just wanted to share this. When you're referring a baby with prostaglandin on flow, what precautions will you take? So here with umbilical line and prostaglandin, you're referring the baby to higher centers. So what precautions will you take during transport? So mainly
continuous monitoring.
Yes, monitoring
Continuous
is
monitoring
one.
should be done. The
Yes.
baby can go into apnea, so continuous monitoring should be done.
Okay. So preferably, as you told, already we are giving the loading dose, as you pointed, 100 mg per kg to 200 mg per kg. Because many of the time we may not have the cardiologist to tell whether duct is open or duct is closing, what is the size of the duct, that we may not be knowing. So to decrease the maintenance dose. So preferably these babies, we may have to intubate the baby, because on the way in transport, if baby goes for apnea, it may be difficult this one. So I would suggest, maybe I had the experience of that. So we referred, baby was stable, but on way I had to intubate. So it may be preferable to intubate the baby. And what percent oxygen will you use while intubation and ET by ventilation? Will you use oxygen or will you not use oxygen?
So the oxygen is not usually indicated.
Correct. Yeah. So unless if you're telling, you can discuss with cardiologist also what should be the target saturations. For individual conditions, they may keep a individual target saturation. So if it is not met, maybe you may have to add little bit of oxygen, and that too without reservoir. Don't use 100% oxygen, because that may go for closure of the duct. And preferably in a room where you can intubate the baby. And ET bagging, maybe as you pointed out, most of them may be term babies, so you may not need any TPs and all. So ET bag with routine positive pressure ventilation bag and mask will be ideal. So preferable, because of the risk of apnea, as you pointed out. So and again, we are giving a high dose, that is the 100. When compared to the maintenance dose is only 5. So that is 20 times higher dose. The risk of apnea will be little bit higher. So that's it. Otherwise, it was an excellent presentation, and both, I think, in our experience also for past 5-6 years, many of the conditions were a pulmonary condition only, as you pointed. One, you had pulmonary atresia, and another one was also DORV. So these two only we also here saw in our hospital also. And the second baby told the antenatal scans did not detect, no?
It's
So what do you feel? So how good are antenatal scans in picking up the cardiac condition, especially critical congenital, that is non-syndromic? That is, baby is otherwise does not have any syndromic features. We are not thinking trisomy 21 and other things. So how good are antenatal scans in picking up this condition?
So the antenatal scans have a sensitivity of 50% in picking out the critical congenital heart disease.
Very good. So especially if it is non-syndromic, the pickup rate is only 30 to 40%. So most of the cases will be missed even in well-established centers. So irrespective of antenatal scans, so it is essential for us to do pulse oximetry screening to identify the critical concern. That is a very valid take-home message. Thank you.
Thank you, sir.
Thank you, sir, Dr. Ashok, for your very insightful observations and key messages to our PGs. Any other questions from the forum? In that case, I think we can proceed to the next presentation. I request Dr. Anjana from Chettinad Hospital to please begin her presentation. Dr. Anjana?
Yes, ma'am. Yes, ma'am. Is it visible, ma'am?
Yes, visible, pa.
Yes, it is visible now.
Okay. So, good afternoon. My name is
1 minute,
Dr. Anjana B.S.
Anjana, Dr. Anjana, 1 minute. Sorry for the interruption. We'll have the timer from now on. It will be like total 10 minutes of presentation with 1 to 2 minutes of extension and 3 minutes of discussion. Okay. So
Okay, ma'am.
sorry that for the past presentation, I missed to switch on the timer. So we'll stick on to the timing. Okay. Thank you.
Okay, ma'am. Good afternoon, everyone. I'm Dr. Anjana from Chettinad Medical College. Today, my topic is Not All Vomiting is Gastritis, Unveiling the Hidden Pan Beneath. My moderator is
Anjana,
Dr.
sorry to
Bhuvaneshwari, ma'am.
interrupt, Anjana. Anjana,
Yes,
can you
ma'am.
put it in the viewer mode, the full screen mode?
Yes, ma'am.
Thank
Is it visible?
Yeah, it is visible, but not in full screen. Yes. Thank you, Anjana.
Yes. Okay, ma'am. So, my moderator is Dr. Bhuvaneshwari, ma'am,
Anjana, your
Associate
audio is
Professor,
breaking.
Chettinad Medical College.
Anjana?
So,
Yeah.
a 12-year-old female child who is
Anjana, we can't hear you. Your audio is breaking.
12-year-old female child developed.
Anjana? Anjana, we can't hear you.
Hello, my audio is clear, ma'am.
It's breaking. Yeah, maybe your internet is breaking or audio is breaking. We are not sure which. Please start. We'll see how it goes.
Yes, ma'am. Yes, ma'am. So, a 12-year-old female child, developmentally normal, immunized for age, brought by her parents whose reliability is good on September 25th, 2025, with presenting complaints of abdominal pain for 1 day, vomiting of 6 to 7 episodes for 1 day. So, history of presenting illness. Child presented with complaints of diffuse abdominal pain, insidious in onset, continuous in nature, non-radiating, with no aggravating or relieving factors. History of vomiting, 6 to 7 episodes containing food particles, not bile or blood stain, non-projectile, non-foul smelling, not associated with food intake. History of reduced oral intake. History of outside food consumption was present. No history of any loose stools or constipation. No history of abdominal distension. No history of burning, maturation, fever, jaundice, or no history of any recent travel. No history of altered sensorium or seizures. No history of any reduced urine output. So, past history, child had history of laparoscopic appendectomy done 2 years back, and another child was admitted at CHRI on July for GERD and was treated symptomatically. Antenatal history, spontaneous conception, antenatal scans were normal. Mother had hypothyroidism during pregnancy, for which she took thyroxine 100 mcg OD. Natal history, term pregnancy, birth weight of 3.75 kg, LS in of LGA, cried immediately after birth, no history of any NICU stay. Developmentally, all milestones attained appropriate for age, child studying in 7th standard with good scholastic performance. Immunization history, immunized till age. Family history, second born of non-consanguineous marriage. No history of TB, asthma, chronic liver diseases in the family. Diet history. Observed is 2,850 kilocalories with excess of 790 kilocalories. Protein intake of 29 gram with a deficit of 9 grams. Child belongs to upper socioeconomic class according to modified Kuppuswamy classification. So, summary, 12-year-old female child, second born of non-consanguineous marriage, developmentally normal, completely immunized, with just complaints of diffuse abdominal pain with vomiting for 1 day and a past history of laparoscopic appendectomy 2 years back. So on admission, child is alert, active, afraid, no pallor, icterus, cyanosis, clubbing, edema, or lymphadenopathy. Primary assessment, airway stable, breathing RR of 90 per minute, bilateral air entry equal, no added sound, saturation maintaining at room air, circulation heart rate of 88, BP was also 110/70 in the 1590 centile, CRT less than 3 seconds, peripheral pulses are well fit, CBG normal, other exposure, child is febrile. And coming to anthropometry, child BMI falls is actually 25.8, which is more than 27th adult equivalent, which is obese. And head to toe examination was normal, and SMA staging of 3. And coming to the systemic examination, per abdomen examination, inspection, shape of the abdomen flat, abdominal movement, all quadrants moving equally with respiration, skin appears normal, no ulcerations, umbilicus inverted, central not displaced, no visible pulsations or any peristalsis, and genitalia normal female phenotype. So coming to palpation, abdomen is soft with just periumbilical tenderness with no organomegaly, no guarding, and percussion, no shifting dullness, and auscultation, bowel sounds are well heard. All other systems are within normal limits. And so initially our differential diagnosis was just acute gastritis, gastroesophageal reflux disease, and pancreatitis. So initial investigations was done, CBC done was normal, electrolytes and RFT was also normal. So because of severe abdominal pain, we did to rule out pancreatitis, and amylase and lipase were within normal limits. So child was initially started on with IV maintenance fluids, managed symptomatically with proton pump inhibitors and antiemetics, but still child continued to have pain, abdomen and vomiting not cleared by all those medications. And to rule out any surgical causes, we took an X-ray at abdomen, which was also normal. And USG abdomen was also done, but it showed a well-defined cystic lesion, which was measuring approximately 1.6 to 1 coracal cyst with some mild to moderate ascites. So again, child developed severe diffuse pain in abdomen with persistent vomiting, now turning 2 to 3 episodes in bilious in nature. And the child had abdominal distension with periumbilical tenderness, and now the bowel sounds also started diminishing with stools not passed. So initially the investigations MRA and CCT was done, and which showed distension of jejunum and proximal ileum measuring 3.5 centimeter, which was suggestive of subacute small intestinal obstruction, probably due to some adhesion with transition point in mid-ileum. So the pointer one was that adhesion, and the ones in front of was the dilated bowel loops. So then we repeat again an X-ray, and that X-ray abdomen showed multiple air fluid levels, which was suggestive of small bowel origin obstruction. And the diagnosis was acute small bowel obstruction, which was secondary to adhesion, most due to post-appendicectomy. And we repeated electrolytes, and so potassium was falling. And management, child was started on IV ceftriaxone and metronidazole, and vitals, girth, urine output were monitored during the hospital stay. So in view of persistent bile, general surgery opinion was sought, a Ryle's tube inserted for gastric decompression, and child was shifted to PICU for further observation. Child catheterized for bladder decompression, and continuous urine output monitoring was done. So in view of low potassium levels, potassium correction was done with maintenance fluids in view of, hypokalemia, and bilious aspirates were replaced with ringer lactate every 6th hourly. And then pediatric surgery opinion sought, and they advised emergency laparoscopic surgery. And surgery was done, and you can see a thick adhesive band, and you can see dilated bowel loops. And these adhesive bands was actually with a connection between the mid-ileum and transverse colon, which was the one which was causing the small bowel obstruction. And it was actually divided. and the obstruction was relieved, and the peristalsis is almost slowly beginning to appear. So operative steps, we can see dilated jejunal loops with the collapsed distal loops, and which was confirming our mechanical obstruction. And we can see, we saw the dense adhesive band, which was actually extending from the distal ileum to the transverse colon, causing the obstruction. And the band was divided using the bipolar. So post-surgery, child was shifted to ICU for observation, started on antibiotics, and POD2, no further episodes of vomiting, no abdominal pain, no distension, and bowel sounds heard, and started with liquid diet, and trials tube aspirate was 2 ml, and NG tube was removed. And POD3, child symptomatically better, started on solid diet, stool spa shifted to ward. And you can see potassium and improved RFT is also normal. And child became symptomatically better, hemodynamically stable, and discharged with dietary advice and followed up with a pediatric surgeon. So small bowel obstruction, which is actually leads to accumulation of gas, fluid, secretions proximal to the obstruction. And as we know, the pressure builds, venous and lymphatic return are impaired, causing edema, ischemia, and eventually severe necrosis. And in closed loop, the risk of ischemia is severe. So etiology can be intrinsic, extrinsic. Extrinsic includes malrotation, congenital bands, postoperative adhesions, hernias, volvulus, and all. Intrinsic causes include atresia, duplications, foreign bodies, and inflammatory structures. So there can be congenital band as well as post-operative adhesive band. But our case, we know that the child underwent an appendectomy 2 years ago, and child, it is not a neonate or an infant, it's like 12-year-old, 2 years post-surgery. And operated, the adhesion was between the operator on inflamed surfaces, which was done for the appendectomy. And free fluid was also noted, which was not seen in congenital band, and thus confirming our diagnosis of post-operative adhesion band. So usually small bowel obstruction, we know presentations, vomiting, abdomen pain, distension, feeding intolerance. Younger infants have feeding intolerance, irritability, vomiting, and abdominal distension. And physical examination, we know it shows tenderness and signs of peritonitis if complication has developed. Imaging or workup, we can take plain abdominal x-rays and look for dilated loops, absence of gas distally, and the contrast studies, ultrasound, CT can be used depending upon the suspicion. So treatment, prompt recognition is critical because delaying the diagnosis can lead to the bowel ischemia, necrosis, and sepsis. Usually, operative management is the best one. And in surgical cases, what we do is we relieve the obstruction, reset the non-viable bowel, repair the underlying lesions like bands or hernias. So the take-home message is, depending on the cause, how early it is detected, and whether bowel compromise has occurred, the prognosis is good. Like if a significant length of bowel is necrotic, there can be serious complications. That's why early identification is very prompt. So thank you. This is the child. She's happy and she went home. Thank you.
Thank you, Anjana. That was a wonderful presentation. That little child looks very sweet and not obese, but anyway.
Yeah,
Yeah, just one little query. Obviously, it was the band which caused the intestinal obstruction, but could you just put in a word about that urachal cyst which you found out? I mean, what would be the presentation? Could it contribute in
yes,
any way to
ma'am. But it was there in USG alone, ma'am.
management?
That's why we did.
Ma'am, this is Dr. Bhuneshwari. I'm the moderator. Usually, the diagnosis of intestinal obstruction due to adhesions by CT, when you see there are some signs, you cannot actually say it is due to the adhesion. There are some underlying clues from the CT. What we saw probably in ultrasound was like in CT, you see as a clustering of loops together, the dilated bowel loops. Whether the ultrasound finding that we saw like dilated cyst-like picture was due to this clustering of loops, we don't know. We didn't go back to the, because ultrasound is more of subjective. So it could be the clustering of loops due to the small intestinal obstruction itself. So it might not be urachus at all.
Okay, madam. Thank you. Any questions from the forum? In that case, can we proceed with the next presentation? I invite Dr. Gokila from Kamakshi Memorial Hospital with her presentation. Dr. Gokila, please.
Yes, ma'am. Good afternoon, ma'am. Is my screen visible, ma'am?
Yes, Gokila, we can see your screen nicely.
Yes, ma'am. Good afternoon, one and all. I am Dr. Gokila, final year DNB resident from Dr. Kamakshi Memorial Hospital. I am going to present a case decoding the puzzle of pyrexia with cachexia. And my moderator is Dr. Prahada, Senior Consultant, Department of Pediatrics and Neonatology, Dr. Kamakshi Memorial Hospital. And I thank my clinical lead, Dr. Rajeshwari ma'am, who have given this opportunity to present this interesting case before this august audience. And coming to the presentation, chief complaints, a 14-year-old adolescent boy presented with loss of appetite, altered bowel habits, weight loss for 6 weeks, with fever for 4 weeks on and off. History of presenting illness, the child presented with fever for past 4 weeks on and off, which was intermittent low grade initially, and child continued to have continuous high grade temperature for past 7 days. History of vomiting for present for the past 1 week, 2 to 3 episodes per day, non-bilious vomiting, not bloodstain, persistent vomiting. Bowel habits, history of altered bowel habits noted for the past 6 weeks. The child found to have 3 to 4 episodes of loose stools per day for 2 to 3 days, followed by normal stools. And child had complaints of early satiety, loss of appetite for 6 weeks, and weight loss around 6 kgs in 6 weeks. And this child was initially evaluated at another branch of us at Medavakam. In the early October, child had early satiety, loss of appetite, altered bowel habits, and weight loss. Hence, the child was initially evaluated with preliminary lab showing normal total count, anemia with thrombocytosis, and other workups were normal. LFT, RFT, vitamin D, thyroid profile, and vitamin D12 level were normal. Hence, the child was initially treated conservatively and he was given oral iron supplementation. But the child found to have fever which is not resolving, evening rise of temperature for around 20 days. Hence, they contacted the physician again, where the labs were repeated and culture sent and oral antibiotics started around 23-10-25. But in view of persistent fever and elevated CRP in the workup, the child is referred to main branch for further evaluation. The dengue test, malaria, blood cultures done there were negative. And in the past, child had noted to have perianal abscess in May 2019, for which he was undergone incision and drainage, and history of fissure in ano in September 2020. Initial workup done at our primary branch, Medavakam branch, was showing a mildly elevated total count with relative neutrophilia, and hemoglobin drop was there from 10.3 to 9.9, and CRP was initially 22.6, which elevated to 75, and in view of persistent high-grade fever, elevating inflammatory marker, child is referred here. And the birth history, the child is born out of non-consanguineous marriage, first child term gestation, delivered by normal vaginal delivery, who was appropriate for gestational age. Birth weight was 2.8 kg, cried immediately after birth, no NICU admission. Development history was normal, and he was immunized up to date. Under an examination, child was looking dull, he was febrile, CRT was less than 2 seconds, warm peripheries, pulse volume was 3+2+, and his vitals were noted. He had temperature of 101 degree, and his respiratory rate was 28 per minute, saturation was normal, and pulse rate was 116, and blood pressure was normal. His physiological status was airway stable, breathing effortless, tachypnea, and circulation was normal. And on general examination, he was thin-built, he was pale, and he had glossitis. There was no icterus, cyanosis, clubbing, lymphadenopathy, or no pleuritic edema. His anthropometry, his height and weight was below -2 standard deviation, and BMI was around 25th centile. And on systemic examination, per abdomen, he had scaphoid abdomen with no distension or no tenderness, no visible veins or free fluid. His hernial orifices were free. And in perineal examination, there was leaking of fecal matter at 2 o'clock position on the left side of the anal verge. And per rectum, there was a chronic fissure in ano at 3 o'clock position, but there was no pus or blood discharge. Other systemic examinations were normal. So to summarize, we have a 14-year-old adolescent boy with added bowel habits, loss of appetite, weight loss, pyrexia of unknown origin, with a perianal fistula and fissure in ano, with a lab showing anemia, thrombocytosis, and elevated inflammatory markers. Hence, our provisional diagnosis was to rule out abdominal tuberculosis and pediatric inflammatory bowel disease. Hence, we started the workup. Initial blood investigation shows further drop in hemoglobin from 9 to 8.6, and total count was little normal with relative neutrophilia, 73.1%, and CRP was further elevated from 75 to 103. And other infective workup and inflammatory workup, Manto was negative, anti-leptospira IgM was negative, scrub typhus antibody was negative, urine and blood cultures were sterile, and ANA-ENA was negative. Respiratory panel showed enterovirus infection. So initially the child was started on empirical antibiotics, ceftriaxone and metronidazole with other supportive care. But the child continued to have persistent fever and rising CRP. Hence, antibiotic was escalated to meropenem. And we have done a contrast CT abdomen, which showed a long segment circumferential wall thickening involving transverse colon and splenic flexure. And further workup, resting gastro samples were sent for AFB analysis, which was negative, and quantiferon TB gold was sent, which was negative. Specific biomarker, fecal calprotectin was done, which showed positive 5,440 microgram per gram of stools, which was positive. Hence, we planned for UGI endoscopy and colonoscopy under IV sedation. And upper GI endoscopy done, which showed a normal esophagus and erosive gastritis, which was pan-erosive gastritis. We can able to see erosions in body, antrum, and fundal portions of the stomach. So child had pan-erosive gastritis. When proceeded with colonoscopy, we found we saw the normal terminal ileum with some part of ileum showing mucosal edema, cobblestone appearance, and longitudinal ulcer. And there were intervening normal colonic anatomy, and we can able to see an ulcer, large longitudinal ulcer in anal verge also. So this is suggestive of terminal ileitis, ulcers with cobblestone appearance, probably Crohn's colitis. Hence, histopathological examination was done. Histopathological examination of gastric mucosa, which showed gastric mucosal edema with lamina propria showing some moderate to chronic lymphoplasmacytic infiltration, showing a chronic active gastritis picture, but H. pylori was not identified. This is picture of biopsy from terminal ileum. Terminal ileum with the lymphoid follicles. Terminal ileum is showing terminal ileitis. Inflammatory cells are present in the ileum. So gastrium involved, ileum also involved. Coming to colonic biopsy, there are two pictures. First one showing the same child's colonic mucosa from normal colonic glandular architecture. The biopsy taken from the normal side, and the adjacent picture is showing inflamed colonic mucosa with inflamed glands. So this is suggestive of skip lesions. And in this picture, we are able to see many cryptitis and cryptapsis. That is, inflammatory cells infiltrating the epithelium as well as the lumen of the crypts. Hence, it is cryptapsis and cryptitis and cryptapsis was present. And there was a non-caseating granuloma in this cells with a giant cell. So, presence of granuloma with giant cells. And these tissue analyses were sent for microbiological workup also. The microbiological workup showed a negative gram stain AFP stain gene expert, but culture was positive for carbapenemase producing E. coli, which was sensitive to tigecycline. And we have, in view of fistula in the examination, we have done an MR fistulogram, which showed hyperinsulin fistula tract in left anterior within the interspinx plane, and which is positive for the fistula. So the final diagnosis of Crohn's disease was made. Crohn's disease involving the entire alimentary tract from stomach, ileum, and colon, with the perianal disease having fistula. Hence, the child is started on enteral nutrition, liquid diet initially, Mesalazine granules were started 2 grams twice daily. According to cultural sensitivity, injection tetracycline was given for 7 days. Probiotics were added. Intravenous methylprednisolone 15 mg was started for initial 3 days, followed by oral prednisolone 20 mg once daily. This is the picture which is showing the entire workup of the child. There was, after the treatment, hemoglobin improved and the inflammatory markers were reduced, and child was, with the treatment, the child showed a sense of well-being, appetite improved, oral intake improved. He attained a weight gain of 1 kg and child was discharged in stable condition. And he was advised to follow up for growth monitoring and pediatric chronic disease activity index assessment, blood inflammatory markers, and serial fecal calprotectin monitoring. So discussion, pediatric inflammatory bowel disease. Pediatric inflammatory bowel disease. Pediatric inflammatory bowel disease is used to represent 2 distinct disorders causing idiopathic chronic intestinal inflammation, which is Crohn's disease and ulcerative colitis. Pediatric inflammatory bowel disease is caused by dysregulated or inappropriate immune response to environmental factors in a genetically susceptible host. Annual incidence rates are as high as 11.4 to 100,000 person years in Asia and Middle East compared to 15.2 in America. Crohn's disease. Crohn's disease is an idiopathic chronic inflammatory disorder of bowel which involves the entire alimentary tract from mouth to anus. Prevalence is 43 per 100,000 children. The inflammatory process in Crohn's disease tends to be eccentric and segmental. There are skip lesions. Normal regions of bowel is in between the inflamed area and the inflammation is transmural. Crohn's disease tends to have a bimodal age distribution, first peak beginning in the teenage. And the types of Crohn's disease are inflammatory, stricturing, and penetrating. And the presentation differs according to the types. Inflammatory Crohn's presents as diarrhea, bleeding, cramping. Stricturing Crohn's presents as right lower quadrant pain. Penetrating Crohn's presents as fistula and abscesses. The disease phenotype changes as duration of the disease lengthens. Inflammatory to stricturing, stricturing to penetrating. And the clinical features have systemic signs, intestinal signs, extraintestinal signs. Systemic signs, fever, malaise, easy fatigability, growth failure, and delayed bone maturation. In intestinal signs, depending on the site involved, the features differs. If gastric and duodenum involved, there will be recurrent vomiting and epigastric pain. If there is intestinal obstruction, there will be cramping abdominal pain, intermittent abdominal distension. If perianal disease is there, there can be skin tag, fistula, deep fissure or abscess. Penetrating disease, the fistula formation can be there. Abscesses, intra-abdominal abscess, hepatic, splenic abscess, psoas abscess, anorectal or perianal abscess can be present. Extraintestinal manifestation in oral cavity, aphthous ulcers can be present. Peripheral arthritis can be present. Erythema nodosum, digital clubbing, episcleritis, venous thrombosis, pulmonary disease, and renal stones can also be present. The diagnostic workup in a suspected pediatric IBD. Diagnosis is based on history and clinical examination, laboratory examination, imaging, esophagogastroduodenoscopy, ileocolonoscopy with histopathology. Initially, the blood test should be done to rule out urinary infection. Infective workup should be ruled out. Complete hemogram, CRP, ESR, liver function test, and specific biomarkers like ASCA and PANCA. And to rule out infective etiology, and Crohn's is the strongest mimicker of tuberculosis abdomen. Hence, all possibilities should be done to rule out tuberculosis, intestinal tuberculosis, like Manto, IGRA, tissue fluid analysis, HPE, and other infections like Entamoeba histolytica, school microscopy, Clostridium difficile should be done, and HIV serology testing should be done. Fecal inflammatory markers like fecal calprotectin and fecal lactoferrin should be done. In radiology, MR enterography and CT enterography. And for diagnosing pediatric IBD, upper GI endoscopy, ileocolonoscopy, and histopathological examination is must. And this is pediatric Crohn's disease activity index, where we can actually classify the child into inactive disease, mild, moderate, or severe disease based on these clinical parameters of abdominal pain, stools per day, general well-being, weight, height, and per-abdomen findings, perirectal disease, extraintestinal albumin with PCV and ESR in labs. With these, we can classify the child into having inactive disease, mild or moderate disease, because there can be frequent flare and relapse. And the differential diagnosis is acute terminal ileitis, infectious colitis, enteric parasites, periappendicular abscess, protein-losing enteropathy, GI tuberculosis, gluten-sensitive enteropathy, small bowel lymphoma, and immunodeficiency. And treatment of pediatric inflammatory bowel disease, Crohn's, includes induction phase and maintenance phase. For induction, first is exclusive enteral nutrition, primary nutritional therapy that provides 80 to 100% of nutritional needs in liquid formula. The formula should be given by oral or NG tube or gastrotomy for 6 to 12 weeks. Higher remission rates by promoting mucosal healing compared to steroids. Reintroduction of regular diet can be done gradually at the end of exclusive enteral nutrition. If there is no clinical response in 2 weeks, alternative therapy should be initiated. And the alternative therapy includes corticosteroids, which is indicated if exclusive enteral nutrition is not available or not tolerated. Given at full dose for 2 weeks, and then we should taper. For severe Crohn's, IV methylprednisolone can be used. For mild to moderate, oral prednisolone can be used. And antibiotics role is present in the type of perian disease most commonly used in fistulous type. The antibiotics used are metronidazole, ciprofloxacin, and azithromycin, or antibiotic according to the culture and sensitivity. And for maintenance, we use immunomodulators, 5-aminosalicylate, and biologicals. 5-aminosalicylate, mesalamine, 50 to 100 mg per kg per day oral, maximum 3 to 4 grams, used in both induction as well as maintenance. Immunomodulators in maintenance, azothioprine and methotrexate can be used. And biologicals, anti-tumor necrosis factor inhibitors in refractory Crohn's disease, Crohn's perianal fistulizing disease. It can be used as induction as well as maintenance. Take-home message: pediatric inflammatory bowel disease are chronic immune-mediated disorders that primarily affect the gastrointestinal tract and are characterized by alternating periods of inflammation and remission. 25% of all IBD have their onset in children less than 18 years of age. Incidence of disease is increasing internationally. Pediatric inflammatory bowel disease comes with unique additional challenges such as growth impairment and pubertal delay. Crohn's disease are often greatest mimicker of abdominal tuberculosis. Hence, all efforts should be made to differentiate the both. Early recognition and endoscopic evaluation is a key for early diagnosis. Initiation of appropriate treatment reduces the morbidity and increases the quality of living. Thank you.
Thank you, Kokila. That was a nice, elaborate presentation of a very important disorder. I think future generations are going to see more and more. In our generation, we saw more of infections and very little of this, but you people are going to see a lot of it. Thanks for a very elaborate presentation. Just one query. If I remember right, his clinical symptoms began, let's say, I think about 6 weeks or so ago. But from the past history, he had this fissure in ano and anal abscess several years back. So what was the past history since the onset of that anal abscess and perianal chronic fissure in ano? How was the presentation? Did the illness begin then, or how was he otherwise? Just a small query. Thank you.
Ma'am, this is Dr. Prayada. I'm the moderator. Ma'am, he was treated outside for that, ma'am. For the perianal abscess initially. This is the first time he's presenting to Kamakshi, and they have drained thinking it is a perianal abscess outside, but he didn't have chronic complaints on that. And in between, he's had some episodes of abdominal pain, but nothing very significant, ma'am. So we are not sure whether we can take the onset of disease from then. But yes, when we investigated the abscess, now it was active fistula.
Thank you, madam.
Yes.
Any other questions?
Ma'am, nice presentation, ma'am. Actually, we don't often get to see IBD cases. Could you throw more about the elemental diet, ma'am, for this child? What was given? And what route we adopted? Orally, the child was able to take.
Sir, sorry, sir, we are not able to hear you.
Audible, ma'am?
Yes, sir. Now better, sir. Yes.
The word about the elemental diet which you gave the child, route, was the child able to take orally?
The child was started on NG feeds, which also he didn't want to have, sir. He's a bigger child, so he took it off. We tried orally, which also he vomited. He begged to us to give normal diet, sir. So we had to, we were not able to continue with the elemental nutrition.
So only the anti-inflammatory only.
Sorry, sir?
Only the anti-inflammatory were given. So elemental
Yes,
diet.
yes, sir. We put him on elemental diet, but it was not successful with him, sir. He refused to drink.
Okay. Thank you.
Any other questions from the forum? Shall we proceed with the next case? I request Dr. Subhashri from Sri Balaji Medical College to begin her presentation, please. Yes, Subhashri?
Yes, ma'am. Am I audible, ma'am?
Yes, ma'am.
Yes. I'm Subhashri, Paediatrics postgraduate from Sri Balaji Medical College and Hospital.
Subhashri, can you put it in? Subhashri, can you put it in full screen mode, presentation mode?
Yes, ma'am. How do you? The full screen.
If it's difficult, then you can continue. We can see your screen well.
Okay, ma'am. So shall I continue? So shall I continue, ma'am?
Yes, please.
So today we are talking about an uncommon presentation of a common infection. So,
Dr. Subhashri, you are not audible. Dr. Subhashri? Dr. Subhashri? You're not audible. Your voice is not audible.
No.
Dr. Subhashri, are you there? Dr. Subhashri?
Yes, ma'am. Can I continue now? Are my slides visible? Am I audible?
Your
Yes.
voice
This
is
is a case of an
actually
8 years old girl child who came with complaints of abdominal pain for 3 days and fever and vomiting for 2 days. The child was apparently normal 3 days back, after which child developed abdominal pain in the epigastric region, on and off, non-radiating, no aggravating or relieving factors. The fever was for 2 days, high-grade intermittent, associated with chills. During the interfebrile period also, the child was dull. Vomiting was there for 2 days, non-projectile, non-bilious, and not blood stain. There was no history of loose stools. Oral intake was reduced, and history of regular outside food intake present. Past history, the child was admitted 3 weeks back at ICH between 13 September to 22nd September for 10 days with similar complaints and a compensated shock. Resuscitated. The child was extensively evaluated for fever and abdominal pain, right hypochondrial and mild diffuse tenderness present with no guarding or rigidity. Bowel sounds were present. Investigations showed a total leukocyte count which was within normal limits, and CRP which was positive, and amylase and lipase which were elevated. Viral dengue, scrub typhus, microscopic agglutination test, blood culture, urine culture were all negative. The child was then subjected to imaging. In which the ultrasound distended gallbladder with presence of sludge and mild edema. CT abdomen showed grossly distended gallbladder with
Dr. Shubhashri, your presentation is not moving. Your slides are not moving. Dr. Shubhashri?
Subhashri,
Yes, ma'am.
we can't hear you and your slides. You can actually put it in full screen when you go to the right bottom corner of your presentation. And we can't hear you too well. Can you hear us, Subhashri? Subhashri?
Ma'am, Padma ma'am, I guess there is some network issue.
Okay.
Can we proceed to the next?
Am I audible now, ma'am?
Yes, we can hear you now. Yes, loud and clear.
Yes, ma'am. Thank you. Sorry for the delay. So
No problem.
I will continue from the imaging, ma'am. So at ICH, at the time of presentation, the child was subjected to imaging, which showed an ultrasound abdomen findings of gallbladder distension with the presence of sludge and mild edema. CT. CT CT abdomen showed a grossly distended gallbladder with diffuse wall edema and diffuse fat stranding. So, in the right subhepatic region, diffuse periportal edema was present, and appendix was mildly thickened with multiple enlarged mesenteric lymph nodes, with largest measuring 9 mm. Probable acalculous cholecystitis diagnosis was decided on. This is a CT imaging. There's a CT imaging present, and then past history. The pediatric surgeon opinion was obtained and advised conservative management. In view of persistent high-grade fever spikes, the child was treated with injection ceftriaxone for 2 days, and injection piptas for 7 days, and injection amikacin for 7 days, and capsule doxycycline for 7 days, and injection meropenem for 5 days, and other supportive medications. The child was reviewed once at ICH after discharge. At the time of presentation to Balaji OPD, it was a developmentally normal for age child, immunized up to age according to national immunization schedule. Optional vaccines were not given for the child. Typhoid vaccine was also not given. On examination, the child was febrile and mildly dehydrated. Abdominal examination revealed diffuse abdominal tenderness with guarding, no rigidity and sluggish bowel sounds. There was no jaundice or hepatosplenomegaly. Case summary: an 8-year-old girl presented with abdominal pain for 5 days, along with fever, non-bilious vomiting, and poor oral intake. History of regular outside food intake was present. Abdomen examination revealed diffuse abdominal tenderness with guarding, no rigidity, and sluggish bowel sounds. So, from the history, we could get a differential diagnosis of acalculous cholecystitis, probably infective etiology, acute appendicitis, acute pancreatitis, and peritonitis. Investigations at the time of admission showed a total leukocyte count, which was within normal limits, elevated neutrophils, positive CRP, and raised liver enzymes. Amylase, serum amylase and lipase were within normal limits. Typhi.IgM was positive, suggestive of acute Salmonella typhi infection. And abdominal ultrasound at the time of admission showed a distended gallbladder with the presence of sludge. Child was admitted with the above mentioned complaints on 12th October 2025 and necessary investigations were done. Surgery opinion was obtained and advised conservative management with IV antibiotics. Child was kept nil per oral and treated with IV fluids, injection pan and injection piptas. In view of persistent fever spikes and abdominal pain, repeat ultrasound was done on 16th October. The repeat ultrasound showed a distended gallbladder with wall thickening measuring 4 mm, presence of sludge, a defect measuring 5.5 mm noted in the fundus of gallbladder with surrounding fat stranding. Another defect measuring 1 centimeter was noted in the body of gallbladder in the posterior aspect. There were no gallstones, distal common bile duct thickness around 3 mm, mid and proximal CBD thickness around 3.5 mm. Findings were consistent with acute acalculous cholecystitis with concealed gallbladder perforation. Surgery review and surgical gastroenterology opinion was obtained and advised IV antibiotics and laparoscopic or open cholecystectomy. Child was taken against medical advice to ICH. We obtained a diagnosis of acute acalculous cholecystitis secondary to acute Salmonella typhi infection complicated by gallbladder perforation. At ICH on 17th October, we had a laparoscopy findings of grossly dilated bowel loops. Large bowel and stomach were densely adherent around the gallbladder fossa. No free fluid. Procedure was then converted to open. Mass in the gallbladder fossa with dense adhesion to large bowel and stomach with omental caking. 20 milliliter collection was noted around liver, which was concealed by omental collection consisted of pus, mucus, white bile, and sludge. Posterior surface of gallbladder, large 4x3 centimeter perforation was present. Dissection was done. Post-operative course at ICH, the child was managed with IV antibiotics, piptas and amikacin, adequate hydration with IV fluids, analgesics, and supportive therapy. Was admitted between 17th October to 29th October for a period of 13 days. She showed good clinical improvement, tolerated feeds gradually, and was discharged in stable condition. She was then brought for follow-up to Sri Balaji Medical College and Hospital OPD on 3rd November. Moving on to the discussion part, abdominal pain is one of the most common presenting complaints in pediatric emergency settings. The differential diagnosis is broad and requires careful evaluation to differentiate benign causes from surgical emergencies. Acalculous cholecystitis is known but rare in children. When it does occur, infection including Salmonella is a recognized cause. A gallbladder perforation in children is rare but can occur in severe AAC. Why Salmonella is strongly implicated here? Because of neutrophilia with a normal leukocyte count and a positive typhi IgM, suggestive of active typhoid infection. Salmonella can invade the biliary epithelium, causing biliary stasis, inflammation, necrosis, and in severe cases, perforation. The child has no gallstones, fitting the pattern of infection-related AAC. In this case, the child presented with symptoms overlapping both typhoid fever and acute acalculous cholecystitis, fever, abdominal pain, and vomiting. Ultrasound is a preferred diagnostic tool, with gallbladder wall thickening being the most consistent feature of AAC. Surgical intervention is reserved for cases with worsening symptoms, suspicion of complications, or inability to exclude progressing cholecystitis.
With early intervention, prognosis is good, especially in contained perforations. Delay increases risk of peritonitis, sepsis, and prolonged hospitalization. The child's favorable post-op outcome highlights the effectiveness of early surgical intervention. Due to its rarity, there is no recorded incidence of the condition, but we did come across some reported cases, some with salmonella infection leading to acalculous cholecystitis and gallbladder perforation. To conclude, acute acalculous cholecystitis should be suspected in febrile children with abdominal pain, especially in typhoid endemic regions. Early ultrasound evaluation and timely surgical referral are essential. It is a very rare occurrence, but still to be considered. Serology helps in clinching the diagnosis in late presentations when conventional diagnostics like blood culture sensitivity don't yield results. And this also stresses the importance of typhoid conjugate vaccine, single dose, which can be given as early as 6 to 9 months, though only 60% effective, can help prevent complications.
Thank you, sir. Thank you, sir. Yes, all right.
Thank you, ma'am. I would like to thank Dr. Jagdishwari ma'am and Revati ma'am for helping me through the presentation, and our HOD Sundari ma'am for encouraging us throughout.
Any
Thank you.
questions, Kelly? Questions?
Thank you, Dr. Subhashri. Actually, I would like to just make a small comment. Acalculous cholecystitis is actually not so uncommon in children. Adults, I think, gallstones as a cause of cholecystitis is far more common. But in children, acalculous cholecystitis, we encounter it now and then, especially, I think, acute viral hepatitis. We recently had 2 cases of viral hepatitis who presented with acalculous cholecystitis. And possibly it's that acalculous cholecystitis which leads to more morbidity, longer symptomatology, and pain abdomen. I think viral hepatitis and yes, salmonella, we all know, can lead to acalculous cholecystitis. Very critically ill children with acalculous cholecystitis. I think if we identify, then we know the reason why the child is taking longer to get better. Thank you, Subhashri. Any questions? Everybody must be hungry, I think.
It was nice presentation, ma'am. But we didn't have a culture proof, right, for salmonella.
Culture, no growth. Culture.
Okay, ma'am. Okay, ma'am. Thank you.
I think we are coming to the end of any other questions, or we come to the conclusion of a very wonderful session, lot of learning here. Thank you all.
Thank you, ma'am. We had a wonderful academic feast over the last hour, so I take this opportunity to thank one and all for your participation. We are extremely grateful to the Indian Academy of Pediatrics, Chengalpet, especially our President, Vice President, Secretary, Treasurer, Academic Coordinator, and Academic Convener for their constant support and guidance in organizing this event successfully. We express our heartfelt appreciation to all the HODs of the colleges for your valuable contribution, and we also thank all the moderators and speakers for their excellent academic contribution and for sharing their knowledge and expertise with us. Our sincere thanks to all faculty members, delegates, and postgraduate students for their active participation and enthusiastic involvement. I also express my gratitude to the chairperson, Dr. Padma Ma'am, who conducted the event. A special thanks to Apex Pharma for sponsoring the event. We also acknowledge the efforts of the organizing committee, technical team, and support staff whose behind the scenes work ensure the smooth conduct of this program. Once again, thank you all for making the 31st Chengai Pediatric Meet a meaningful academic success. Thank you.
Thank you.